All right, welcome everyone. Let's dive right into this explainer and investigate the absolutely fascinating microscopic battlegrounds of liver disease. Today, we're going to explore the hidden world of hepatic pathology, and we're going to do it by unraveling a real-life clinical mystery. Now, for those of you gearing up for your medical licensing exams, especially the USMLE, you're going to want to pay very close attention here. We're going to heavily emphasize the high yield, must-know buzzwords, and the precise microscopic features that'll help you differentiate these distinct liver pathologies on test day. From acute and fulminant failures all the way to chronic and autoimmune destruction, we are going to decode exactly what the liver is telling us when we look closely enough. So, let's get right into it.
We're starting off with the case of Avery Gilbert. Avery is a 20-year-old woman who literally just walked into her clinic for a totally routine checkup. Now, Avery has a history of type 1 diabetes, diagnosed way back when she was just 2 years old, and she's been super diligent about managing it with insulin. If you looked at her, she felt perfectly fine. Her physical exam? Completely unremarkable. Absolutely no clinical signs of acute or chronic liver disease. No jaundice, no obvious distress, nothing. But beneath the surface, her blood work revealed that a silent, heavily destructive process was already underway in her liver. This is a classic presentation for the boards. A patient with a pre-existing autoimmune condition who suddenly presents with asymptomatic yet profound liver abnormality.
So let's break down the hard data that actually set off the alarm bells for her doctors. Avery's liver enzymes were absolutely soaring. Her AST was sitting at 127 and her ALT was 198. Both of these are significantly elevated above normal ranges, which is a massive red flag indicating active hepatocyte injury. But here's the major clue, the real curveball. Her IgG levels were severely elevated at over 3,100 milligrams per deciliter. We call this hypergammaglobulinemia. Naturally, your first instinct when you see any liver enzyme elevation is to check for viral causes, right? Well, her viral hepatitis serology came back completely negative. Instead, her autoimmune markers lit up like a Christmas tree. She had an anti-nuclear antibody, or ANA, titer of greater than 1 to 2,560, and she was positive for anti-smooth muscle antibodies, or ASMA. To top it all off, her liver biopsy showed diffuse inflammation packed with lymphocytes, numerous plasma cells, and interface hepatitis.
Okay, let's pull out our magnifying glass. Section 1. Suspect number 1, acute viral hepatitis.
To solve Avery's case, we first need to rule out the usual suspects. If she was actually dealing with acute viral hepatitis, the microscopic landscape we'd see would look entirely different from her biopsy. We would expect to see a variable degree of hepatocyte necrosis, which usually hits hardest in the central lobular zone, accompanied by a heavy mononuclear cellular infiltrate. A massive key feature here is hepatocyte swelling. The cells literally balloon up, becoming enlarged and rounded, with this pale stained cytoplasm just filled with intracellular edema. Now, quick pro tip for your USMLE prep, do not mistake this acute viral swelling for the ballooning degeneration that you typically see in alcoholic steatohepatitis. They are different beasts. Furthermore, in acute viral cases, you'd see spotty hepatocyte necrosis, where single cells, or maybe small clusters, just die off from lytic necrosis, drop out, and are rapidly cleared away by macrophages, leaving behind this collapsed reticulin framework.
And that brings us to a huge, undeniably high-yield buzzword for your board exams, Councilman bodies. Write that down. When hepatocytes undergo apoptosis rather than lytic necrosis, they actually shrink. They develop a deeply eosinophilic, which just means a very, very bright pink, cytoplasm, and their nuclei become pycnotic, or intensely shriveled and fragmented. These are your famous acidophil, or Councilman bodies. As these cells die, they don't just stay put, they are literally extruded, just pushed right out from the liver plates, directly into the sinusoidal lumen, where they just float around until they eventually undergo phagocytosis by macrophages.
Take a look at this. This view brilliantly illustrates what those acidophil bodies actually look like under the microscope. Over on the right side, you can clearly spot these deeply pink, perfectly round apoptotic hepatocytes we were just talking about. Notice how there isn't really an inflammatory response immediately surrounding them? That's classic for apoptosis. It's a very clean, quiet cell death. But then, look over to the left, and you see this broader architectural chaos. We call this lobular disarray. The liver's normally neat, brick-like arrangement of hepatocyte plates is just completely blown apart by this chaotic mix of necrosis, apoptosis, and desperately regenerating cells. But here's the thing. Avery didn't have this on her biopsy, so we've got to keep investigating.
Moving right along, Section 2, fulminant hepatitis, when immunity overreacts. Before we jump into the chronic conditions,
we really have to briefly touch on the absolute most extreme manifestation of acute viral injury. Sometimes, an acute infection just spirals totally out of control, usually because of an overwhelming, hyperactive immune response. This leads to fulminant hepatitis. Now, this is rare, occurring in less than 1% of cases, but when it happens, it is characterized clinically by rapid, catastrophic acute liver failure. Looking at this dramatic comparison really drives the point home. On the left, that does not look like a normal, smooth, meaty liver. It is severely shrunken and covered by this wrinkled, opaque capsule that suddenly looks way too big for the organ inside. Honestly, it's almost like a deflated balloon wearing a coat that's 3 sizes too big. Then, over on the right, the microscopic view is just absolute devastation. More than half of the cut surface is completely necrotic. And you see that green discoloration? That's actually due to extensive bile staining from massive, widespread tissue death.
If we zoom in on these fulminant cases, what we're looking at is diffuse translobular loss of hepatitis. The necrosis can range from confluent patches to what we're seeing right here, massive bridging necrosis. Bridging necrosis is another critical term you need to know. It refers to these thick cords of necrotic, collapsed liver parenchyma that literally form a physical bridge between adjacent central veins and portal tracts, or even from one portal tract to another. Because such wide swaths of hepatitis are just entirely wiped off the map, all that's left behind is this sad, collapsed reticulin framework that gets infiltrated by lymphocytes. Without the healthy hepatitis to keep the liver architecture propped up and expanded, those adjacent portal tracts just collapse in on themselves and approximate with each other.
Okay, let's look at suspect number 2, chronic viral hepatitis.
So, remembering Avery's case, her timeline was much more chronic and insidious. She wasn't in acute liver failure, she just had these asymptomatic, quietly elevated enzymes. So we need to examine what happens when viral infections, like hepatitis B or C, just hang around long term. The absolute hallmark of chronic liver injury is interface hepatitis. Back in the day, pathologists used to call this piecemeal necrosis. What you're looking at here is a portal tract that is densely, heavily infiltrated by inflammatory cells. Interface hepatitis refers to the active, ongoing destruction of the specific hepatocytes that border these portal tracts, a critical boundary we call the limiting plate. This destruction is driven by cytotoxic T lymphocytes that spill right out of the portal tract and launch a targeted attack on the periportal hepatocytes. This process completely chews up and blurs the sharp, normal boundary of the limiting plate, causing the portal tract to expand irregularly. Understanding this is absolutely vital for grasping how chronic liver disease progresses.
Let's see how this concept builds into some very virus-specific clues. While a lot of chronic changes in the liver can look kind of generic, certain viruses leave behind highly distinct microscopic fingerprints. On the left, we're seeing a really distinctive feature of chronic hepatitis C, the presence of these large, dense lymphoid aggregates right within the portal tracts. You also might spot some focal areas of macrovesicular steatosis, basically fat droplets with HCV. Now on the right, we have the undisputed absolute hallmark of chronic hepatitis B, these beautifully demonstrated ground glass hepatocytes.
Now listen up, because the crucial point for the USMLE is knowing exactly why it creates that ground glass appearance. It's not just a poetic descriptive term, it's a direct reflection of the viral life cycle in action. Under light microscopy, the cytoplasm of these cells literally looks like a matte-finished piece of frosted window glass, finely granular and pale pink. This happens because the cell's internal machinery, specifically the smooth endoplasmic reticulum, gets absolutely stuffed to the brim with hepatitis B surface antigen, or HBsAg. The sheer volume of these viral spheres and tubules building up inside is so massive that it often physically shoves the hepatocyte's nucleus all the way to the outer edge of the cell. But let's bring it back to Avery. Her viral serologies were entirely negative, remember? She didn't have the HCV lymphoid aggregates, and she certainly didn't have these HBV ground glass cells.
Which leads us to Section 4, the true culprit, autoimmune hepatitis.
Because all of Avery's viral labs came up totally empty, we have to pivot our investigation to the actual diagnosis revealed by her incredibly high autoantibodies and that hypergammaglobulinemia. She has autoimmune hepatitis, or AIH. This is a type of chronic hepatitis where the body essentially turns its weapons on itself. The pathogenesis is generally thought to be a two-part storm. An environmental trigger, like a random virus, drug, or toxin, initiates a reaction, but it happens in an individual who is already genetically predisposed. Through a process called molecular mimicry, the immune system gets confused and loses its tolerance. In Avery's case, her T lymphocytes started identifying her own liver self-antigens as dangerous foreign invaders. And here is a massive point highly tested on the boards. This genetic predisposition is strongly linked to the major histocompatibility complex class II. Specifically, if a patient has the human leukocyte antigen genes, HLA-DR3 or HLA-DR4, they are strongly predisposed to developing type 1 AIH. And that is exactly what happened to Avery.
When we finally look at Avery's biopsy, we find the smoking gun. While AIH definitely shares some features with chronic viral hepatitis, like that interface hepatitis we talked about, the character of the inflammation is what gives it away. AIH features severe interface hepatitis that is just densely packed with clusters of plasma cells. You can clearly see these plasma cells if you look at a high-power view. They're the cells with those off-center, eccentrically placed nuclei and a really prominent perinuclear clearing, almost like a little halo next to the nucleus. The rest of the lymphocytic infiltrate is made up mostly of CD4-positive helper T cells and CD8-positive cytotoxic T cells. Bottom line, when you are looking at a slide and you see a chronic hepatitis pattern with a super heavy lymphoplasmacytic infiltrate, prominent interface hepatitis, and a ton of plasma cells, your brain should immediately scream autoimmune hepatitis.
To really ace your boards, you have to be able to distinguish between the two major classifications of AIH. Type 1, which is what Avery has, is by far the most common, accounting for about 80% of all cases in the U.S. It's characterized by circulating anti-nuclear antibodies, ANA, and anti-smooth muscle antibodies, ASMA. It also has a really interesting bimodal age distribution, meaning it peaks first in teenagers and young adults between 10 to 20 years old, and then has a second peak later in life between 45 and 70. Type 2 AIH, on the flip side, is defined by different markers entirely: anti-liver kidney microsomal 1 or anti-LKM1, and anti-liver cytosol 1 or anti-LC1 antibodies. Type 2 is way more common in children, specifically between ages 2 and 14, and these patients are much more likely to present with highly active severe disease, sometimes even presenting as fulminant hepatitis right out of the gate.
At the deepest molecular level, these distinct autoantibodies in type 1 and type 2 are actually targeting very specific liver proteins. The leading autoantigen candidate for type 1 AIH is the S-yellow-glycoprotein receptor, or ASGPR. This receptor sits right on the surface of the hepatocyte, making it a prime target. In stark contrast, for type 2 AIH, the major autoantigen has been identified as cytochrome P450-2D6, or CYP2D6. Now, this protein is tucked away inside the cell, specifically residing within the endoplasmic reticulum and the mitochondria of the hepatocytes. Understanding these highly specific targets really highlights the precise, insidious nature of the molecular mimicry that is driving all this destruction. Finally, let's talk about the future. Section 5. Prognosis and lifelong management.
Getting this diagnosis right, identifying autoimmune hepatitis correctly and differentiating it from those viral causes is quite literally a matter of life and death. Historically, before we understood how to manage it, autoimmune hepatitis was a highly lethal condition with a frankly dismal prognosis. Without treatment, up to 50% of individuals with severe disease would die within just 6 months to 5 years. It was devastating. However, with the prompt, aggressive introduction of corticosteroid therapy, the entire clinical course is dramatically altered. Most patients respond exceptionally well to steroids, and their 10-year survival rate absolutely skyrockets to an incredible 83 to 94%. That is a massive turnaround, and it's exactly why rapid recognition of those autoantibodies and biopsy features on your exams and in the clinic is absolutely critical.
But of course, there is a catch. Management for AIH isn't a quick fix, it is a lifelong commitment. We can't just treat it for a few months and call it cured. If corticosteroid therapy is withdrawn, there is a massive, incredibly high 80% relapse rate within just 3 years. But keeping a patient on high-dose steroids for decades? That's going to cause severe, debilitating side effects, things like severe osteoporosis, steroid-induced diabetes, and hypertension. So to get around that, we rely heavily on long-term immunosuppressant. Azathioprine monotherapy is frequently introduced as a steroid-sparing agent. This allows us to maintain that vital disease remission while minimizing long-term toxicities for young patients like Avery.
Even with excellent medical treatment, though, our job isn't done. We have to constantly monitor these patients. You see, chronic hepatitis, no matter what's causing it, sets up a vicious, repeating cycle of ongoing inflammation, hepatocyte death, and rapid, frantic cellular regeneration. Over time, this constant turnover leads to progressive fibrosis, which eventually turns into full-blown cirrhosis.
And once cirrhosis is established, a very real, very dangerous ticking clock starts for the development of primary hepatocellular carcinoma, or HCC. For patients who develop cirrhosis due to AIH, liver cancer develops at a yearly incidence rate of about 3.06 per 1,000 patients. Now sure, that's lower than the 9 to 54 per 1,000 yearly incidence we see in hepatitis B cirrhosis, but make no mistake, it remains a severe, constant threat that requires diligent, lifelong ultrasound and biomarker screening.
Which leaves us with a pretty profound final thought as we wrap up this explainer. The liver is an organ of legendary resilience. I mean, it is capable of astonishing regeneration, even amidst the kind of microscopic devastation we've looked at today. But as we medically suppress the immune system to stop the autoimmune attack in patients like Avery, we have to ask ourselves, can the liver's inherent, miraculous ability to heal itself truly outpace the looming shadow of cirrhosis and hepatocellular carcinoma? It's a wildly delicate balance of managing immunity, pushing regeneration, and mitigating carcinogenic risk, a battle that is fought every single day, right down at the microscopic level. Thank you so much for joining me on this deep dive today. Keep these cellular mechanisms in mind, make sure you master those USMLE buzzwords, and I will see you in the next explainer.